Welcome to our Friday morning Neuroscience and Neuropathology Conference. For those of you who don't know me, my name is Dan Rohr. I'm a neurosurgeon at Providence St. Vincent Medical Center and Director of Cranial Surgery at the Providence Brain and Spine Institute. This is a CME accredited event, and we have been running this for the past 15 years with Dr. Alan Sacker and Dr. Vasco Kamakchev. PBSI Foundation members Bill and Julie Ryersgard and the Jerry Bauer Foundation have generously supported this conference. I would also like to thank our organizers for today's event, which is Diana Moses, Desiree Berkeley here in Portland, as well as Michelle Eng in Swedish in Seattle. Rapid changes in the field of molecular pathology over the past 10 to 15 years have led to dramatic changes in how CNS tumors are classified. With better understanding of how various tumors are separated or lumped together, better treatment should eventually evolve. The 2021 WHO CNS tumor classification will be out very soon. I thought it was already out, but I was just corrected that it won't be out for about another month or two, with a number of critical changes. Today, it is a great honor to introduce Dr. Arie Perry, who will give us a very timely presentation of these changes. Luckily, I received Dr. Perry's short bio because his CV is well over 70 pages long, and I was trying to figure out a way of condensing that. Dr. Perry is Director of Neuropathology and the Neuropathology Fellowship Program at UCSF. He received his MD and residency training at UT Southwestern in Dallas, followed by surgical pathology, neuropathology, and molecular cytogenetics research fellowship at the Mayo Clinic in Rochester under his mentor, Dr. Scheitauer. His interests have focused mostly on classification, grading, and molecular characterization of both adult and pediatric tumors. Dr. Perry has co-authored or authored 600 publications and participated as an editor for the WHO 2016 and 2021 CNS tumor classification updates. He is author of 7 of the 5th edition WHO classification schemes and CMPEC Now updates. He has served as chief editor for Brain Pathology, the Practical Surgical Neuropathology textbook, and Greenfield's Neuropathology. Dr. Perry maintains an active consult service at UCSF, which we have utilized on several occasions, and is frequently invited lecturer worldwide. Dr. Perry is a modern-day medical influencer, and I had to look up the definition of influencer. Not that he's making us buy things online, but in the world of neuropathology, he is a medical influencer. He enjoys creative modes of teaching, making use of long-standing passion for music. Dr. Perry has a beautiful tenor voice and has been featured in several media stories for using neuropathology songs in medical education, including several CD recordings and YouTube videos. I hear we'll get some links at the end of today's talk. My personal favorite, as we had talked about earlier, has to be oligodendroglioma, sung to Schubert's Ave Maria. I think that was just beautiful. As I reflect back on my own neuropathology training at University of Washington a few decades ago, I may have actually learned substantially more only if Dr. Buster Albert and Dr. Cheng-Mei Shaw were able to actually carry a tune like Dr. Perry. Unfortunately, that was not the case. Please welcome Dr. Arie Perry.
Great. Thank you so much, Dan. Let me share this. And give me a second here. Get this going. So thank you, Dan, and thank you, Vasco, for inviting me to give this talk. Let me get it on the right setting. Okay, can everybody see the PowerPoint?
Yes.
Okay, excellent. So, if anybody has seen the version that I gave of this at the Society for Neuro-Oncology, this is almost identical. So it'll be reinforcement, I guess. But anyway, when I thought about the WHO 2021, it really reminded me of 2001, A Space Odyssey, And so I gave it this cute title of WHO 2021 Diagnostic Odyssey. And thinking about everything we went through to get to this point, it really is kind of like a long odyssey. So I'm going to try to help you understand how we got to where we are right now and why we made the changes that we did. I have no disclosures. I'm a typical pathologist. No drug company wants to give me any money, so there you go. So it's early in the morning, so I'm going to give you just this little brief audio clip to get your blood flowing and get you in the mood. Hopefully you'll hear it. So WHO 2021, a diagnostic odyssey. An epic journey or adventure. A long trip or period involving a lot of different and exciting activities, especially while searching for something. An intellectual or spiritual wandering or quest. Alright, so hopefully that at least woke you up a little bit. So don't worry if you miss anything that I talk about today. Almost all of it is included in this review paper by the editors of the WHO that was just recently published in Neuropathology. Here are the editors. Almost all of us are pathologists, except for Stefan Pfister, who is a neuro-oncologist focusing on pediatrics, and Riccardo Soffietto, another neuro-oncologist focusing on the adult side. Okay. Oh, it's getting stuck. Not sure why the slides are not moving. Something is stuck. Let's try that again. Sorry about that. I don't know what caused that. There we go. Alright, so the Odyssey, if you think about it, really starts back in 1979 with the first WHO series. But I'm going to focus on everything that's happened since the publication of the 2016 WHO and how did we get to where we are now with the 5th edition or the 2021 WHO. So fortunately, even though we have a lot of changes, it was a little easier this time around than previously. And that's because we had this group put together called the C-Impact Now, which stands for the Consortium to Inform Molecular and Practical Approaches to CNS Tumor Taxonomy, kind of a mouthful. And the thing that I always thought was really funny about it was the NOW stands for Not Officially WHO. Although the reason I think it's funny is that if you look at the names of the people on this committee, it's virtually all the same people that are also involved in the WHO. So the purpose of these was to publish some updates in between the publications of the WHO so that it's not such a massive change all at once every 5 to 10 years when we publish these things. So you can decide exactly how impactful all these changes are. I think they're probably pretty impactful, but I joke that now it's now officially WHO because, not too surprisingly, we accepted virtually all the recommendations that we made to ourselves in these publications. And there were 7 between the 2016 and 2021, so we'll go through most of those in terms of how we got to where we are. But just quickly to go over some of the nomenclature changes. One is that now we say CNS WHO grade, and the reason for that was the WHO itself pointed out that these are not their grading schemes. They're ours within the CNS tumor group, and occasionally there's some slight differences with our grading schemes and similar tumors in other parts of the body. So to emphasize that it's ours, it's the CNS WHO grade. But probably more importantly, one of the other changes was we were the only ones in the organ systems throughout the body that were using Roman numerals, which is kind of confusing and easily leads to typos and things like that. So now we're conforming to everybody else, and we're going to be using Arabic numerals. More importantly than that, though, is this kind of philosophical shift. So we're now going to be, similar to other organ systems, grading within types or within entities. So what do I mean by that? So instead of saying there's astrocytoma, anaplastic astrocytoma, and glioblastoma, each with its own grade, we have this one entity, astrocytoma IDH mutant, regardless of the grade, and then we add whether it's grade 2, 3, or 4. Similarly with oligodendrogliomas, they're IDH mutant and 1p19q codeleted, and they're either grade 2 or 3. Additionally, the term glioblastoma, which was used for several different entities previously, is now only for the main type that we think about, the classic adult type, IDH wild type glioblastoma. So there's no more IDH mutant glioblastoma, there's no more pediatric type glioblastoma. Those are all given different names than and we'll go through those. There's also kind of a growing list of entities that now are automatically grade 4, so we don't have to grade within those types, and they include, there's a molecular way to get to glioblastoma, IDH wild type. There's a molecular way to get to the grade 4 IDH mutant astrocytoma. On the pediatric side, there's diffuse midline glioma that's H3K27 altered, and a hemispheric glioma that's H3G34 mutant. And there's a pediatric high-grade glioma that's wild type for both IDH and histone 3. And we'll go through all of those, but I just wanted to kind of summarize up front. Really, just to emphasize, this was already introduced, of course, in the 2016 WHO, but is still the biggest change and most important gliomas to separate out are the IDH mutant from the IDH wild type. And this is some summary data from Craig Horbinski's group at Northwestern in Chicago, just to show you how dramatically different these two tumors are and why we consider them completely different entities now. All right, so the journey or the Odyssey begins with the See Impact Now update number 1. And we started off not being too ambitious. We just clarified two terms, not otherwise specified and not elsewhere classified, which have now are being used in the 2021. You can use it with any tumor type. So what is NOS or NOS? Of course, if you're a fan of the Fast and Furious movie series, then that's nitrous oxide system. But in the WHO, it stands for not otherwise specified. And these are the tumors where normally part of the definition is something molecular, but the molecular hasn't been done, or for whatever reason is not conclusive. And NEC or NEC, that stands for not elsewhere classified, and this is what pathologists have always called descriptive diagnoses. So I'll just show you some examples. So let's say I get an H&E from somewhere outside. I don't have a block. It looks like a classic glioblastoma, but I can't do any molecular studies. So I will say glioblastoma NOS, CNS WHO grade 4, and that tells the oncologists that look at my report, it says that, well, molecular studies have not been done on this, and probably we need to add them when we get a chance. Or let's say I get another case, and this one is clearly a high-grade glial neoplasm, but I can't tell which of the high-grade glial neoplasms that is. And then I'll tack on this not elsewhere classified, meaning you can go to the WHO, you're not going to find an entity anywhere called high-grade glial neoplasm. So This is essentially a descriptive diagnosis. Or maybe, the molecular was done. It's a high-grade glioma, and we find this NTRK fusion. But unlike this being this entity of the infant-type hemispheric glioma, maybe this is an adult patient. We're not sure that's really the same entity, so I may put an NEC at the end of something like this. All right, so here's another C-Impact Now update number 6. This is the one that introduced the greatest number of changes. So the journey continues, navigating a dense asteroid field. So we introduced 16 new entities, the nomenclature changes that I already talked about, and some potential future entities. And this came straight out of this in-person meeting that we had in Utrecht in the Netherlands in 2019. You can see we're all smiling and happy. We're all well-fed and wined and dined. And little did we know that this would be our last in-person meeting. There were 2 others scheduled, but as you can guess, a couple months later, the COVID epidemic hit, and from then on, we had to do everything by Zoom meetings. So this is a screenshot that my friend David Lewis took of us during one of these Zoom meetings, and you can see we're not too happy about it. We don't get to be wined and dined in a beautiful European city. Nevertheless, we got through everything. And so in the end, now there's not 16 new entities, but 22 new entities, including 7 in the glioma category, 3 glioneuronal, 4 ependymoma, 4 embryonal, 3 sarcoma, and 1 pituitary. I highlighted this one over here because it's a little controversial in terms of the fact that the only way really to diagnose this tumor type is by DNA methylation profiling. And since only a few people have that available, it's really not ideal. But it's there if you have it. If you don't have it, you're not going to be diagnosing this entity. Fortunately, it's quite rare, so you're not going to be missing it too often. There's also 13 tumor types where the terminology was revised for one reason or another. We'll go through a few of these, but certainly not all of them. But I'm going to start off with the category that I think has changed the most, and that's the diffuse gliomas. And so I'm comparing here the WHO 2016 with 2021, and I put in the Star Wars quote because there's such big changes, so I sense a major disturbance in the force. So on the adult side, this something happened that rarely happens. It actually got simplified. So all of these except one previously were adult type gliomas. All of this has now been compressed down to 3 major types: IDH mutant astrocytoma, oligodendrogliomas, and GBMs, basically. And the reason is we got rid of all of these NOS and these different grade categories because we're grading within the tumor types, as I mentioned earlier. The opposite happened on the pediatric side. So we only had one entity that was predominantly pediatric previously. Now this is expanded to 8 entities, 4 low-grade pediatric type diffuse gliomas and 4 high-grade. And we'll go through all of these so you'll see them. Here is another quote. It is necessary sometimes to take 1 step backwards in order to take 2 steps forward. So our second C-Impact Now update was just some clarifications, and that is that we initially thought in 2016 that the diffuse midline gliomas, this mutation was so specific that nothing else has it. So we thought this was really the only requirement. But since that time, what we found was there are rare pilocytic astrocytomas, gangliogliomas, even ependymomas that also have this mutation. So it seems kind of silly, but we clarified it has to be a diffusely infiltrative tumor, has to be in a midline location, Has to be a glioma, of course, and it has to have this mutation before you make this diagnosis. As you'll see by 2021, this has even evolved further. And then we also, just for practical purposes, clarified that if you have ATRX loss by immunohistochemistry or mutation, that's so specific for astrocytoma that you don't have to perform 1p19q testing to rule out an oligodendroglioma. Oh my God, this is now got stuck again. I don't know what's going on with this. Gremlins. We'll have to do this again. All right. Share. Okay. At least there's a solution. So this is what's actually published now in the WHO 2021. So we did, of course, accept those recommendations. One of the new features you'll see that I particularly like is that every entity has essential diagnostic criteria and desirable diagnostic criteria. So for this entity, needs to be a diffusely infiltrating glioma with an IDH mutation and either loss of ATRX expression or 1p19q codeletion, exclusion of the 1p19q codeletion before you call it an astrocytoma. You still have to grade within this entity, but this part is fairly straightforward now in terms of the definition. So because of that, with our immunohistochemical surrogate markers, if we get a case like this that's positive for IDH1 R132H mutation and has loss of ATRX, often with overexpression of P53, basically we're done. I don't have to do any really molecular studies beyond that because this now fulfills the definition for an astrocytoma IDH mutant, and then we just have to assign a grade. So one of the things we were looking at, because the prior grading schemes for astrocytomas were pre-molecular era, and it turns out they don't really work all that well in the IDH mutant category, we were looking, are there any surrogate markers for grading of these tumors? And the one that seems to be most reliable and reproducible is CDKN2A loss or homozygous deletion of CDKN2A. And so the CMPAC Now Update 5 recommended that regardless of the grade, if you find this homozygous deletion of CDKN2A, those are going to behave like grade 4 tumors. So this is a new molecular criterion for grading these IDH mutant astrocytomas. We accepted that. Most of these otherwise look like grade 3, and you add this and it upgrades to grade 4. They're rare in the grade 2 category. But we're still left with this subjective criterion for grade 3 of anaplasia and whatever you think is significant mitotic activity. There's not really any great cutoff published for these. So there's still some work to be done in grading these tumors. For oligodendrogliomas, there really hasn't been a whole lot of change from the 2016. They're IDH mutant, and normally on immunohistochemistry, ATRX is retained, and there's not a lot of P53, but you still have to do some sort of molecular technique, be it FISH or NGS or CGH or whatever you want to do, to show the 1p19q codeletion, and preferably its whole arm, and then you grade it as either 2 or 3. Now there is this interesting French study that showed that similar to astrocytomas, if you have homozygous deletion of CDKN2A in oligodendrogliomas, they do worse. It's this gray survival curve over here. The problem is that, this is probably less than 10% of all the oligodendrogliomas, and the vast majority of those that have that already look like they're grade 3, so It's probably not going to come into play all that often, but there is a comment, at least in the WHO, that if you have what looks like a grade 2 oligodendroglioma and you find this homozygous deletion, you are able to upgrade it to a grade 3. I think much more impactful and much more common that we see this is what we published in the Update 3. And that is the IDH wild-type GBMs don't always have microvascular proliferation or necrosis. And so, what are the molecular criteria we can use for making this diagnosis? And simply just having a lack of IDH mutation itself is not enough. But looking in the literature, what we all decided was enough is if you have either EGFR amplification, gain of a whole chromosome 7, and loss of chromosome 10 simultaneously, or the TERT promoter mutation, then that allows you to call what looks like a grade 2 or grade 3 IDH wild-type astrocytoma as GBM IDH wild-type. So in addition to the traditional histologic criteria, we now have these 3 molecular criteria that allows one to get to GBM IDH wild-type. And as you would guess, these are nearly always adult patients, and often they're older adult patients. But no sooner had we published this than already there's a warning from the French and European groups here. So a quote from Lost in Space, for those of you old enough to remember this show. Warning, 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 danger, Will Robinson. And there's this publication that says, if the only criterion you have is just TERT promoter mutation in what looks like a lower grade astrocytoma, in this study they had an overall survival of 88 months. And what I think is going on is that probably some of those cases are not really diffuse gliomas at all. They're pilocytic astrocytomas or PXAs or gangliogliomas that just happen to have a more infiltrative growth pattern. But regardless, we have to be a little more careful if that's the only criterion that we have for upgrading to a GBM. So here's another sci-fi quote, again from 2001, A Space Odyssey. Already back in 1967 when they made this movie, they were thinking about artificial intelligence computers, and there's HAL 9000, the artificial intelligence computer, right after it killed most of the astronauts, and the astronaut Dave was trying to shut it down. It said, "Look, Dave, I can see you're really upset about this. I honestly think you ought to sit down calmly, take a stress pill, and think things over." And the reason I use this quote is I thought the hardest of the C-Impact Now updates was for these pediatric low-grade tumors. And Dave Allison was the one in charge of this group. But they did a really great job, I think. They proposed these 6 diffuse glioma entities. They've actually been simplified now for the WHO. So these 2 are biologically related, MIB or MIB-L1. And so we have a diffuse astrocytoma, MIB or MIB-L1 altered. If you have a very specific histologic pattern with MIB-QKI fusion, that's a related entity, angiocentric glioma. Or if you have any of these that are part of the MAPK signaling pathway, that's the diffuse low-grade glioma MAPK pathway altered. And unlike the adults, even though these look like diffuse gliomas, these are all considered biologically grade 1 tumors. So these are 3 of the 4 low-grade that have been added. And the 4th one is a new entity called polymorphous low-grade neuroepithelial tumor of the young, or PLENTY. These are patients with chronic epilepsy, often heavily calcified tumors with an oligodendrocyte-like histology, extensive CD34 positivity, and usually one of two common MAPK alterations, either BRAF V600E mutation or most commonly FGFR2 fusion, very rare cases FGFR3 fusion. So all of these are grade 1, all of the low-grade pediatric diffuse gliomas. So now we're going to move to the high grade, and there are 4 high grade. So remember I talked a little bit about from 2016 the diffuse midline glioma that was H3K27M mutant. This has now been changed to K27 altered, and that's because we now know there are at least 3 different molecular subtypes. By far still the most common is the H3K27M mutant. In rare cases, instead of lysine to methionine, it's lysine to isoleucine, and these are thought to be equivalent. But there's another subtype that instead is driven by EGFR mutation, and these are often bithalamic, but not always. And a third subtype that is driven by EZ-HIP overexpression. And the thing that all 3 of these have in common is this epigenetic downstream effect with loss of the histone 3 lysine 27 trimethylated protein by immunohistochemistry. So all of these are grade 4. They're really highly aggressive tumors. This was a report from our group about these bithalamic gliomas where we saw these fairly distinctive EGFR mutations and mostly exon 20. And here's an example, bithalamic and diffuse astrocytic neoplasm with loss of the trimethylated protein, but yet when we looked for K27M mutation, it was negative, and instead it had this EGFR mutation, sometimes with amplification as well. When we expanded out with our colleagues in Heidelberg, we found indeed these are common. They're not always in the thalamus. They're sometimes in other midline locations as well. The same dismal prognosis, unfortunately, as the H3K27M mutant diffuse midline gliomas. And by DNA methylation clustering, these clustered together, so they seem to be biologically related. And that was the justification for lumping all 3 of these subtypes together. This is the 3rd subtype with EZ-HIP overexpression, again with this dismal prognosis. And here's an example of one. Loss of the trimethylated protein on immunohistochemistry. And instead of K27M mutation, we have this overexpression of EZ-HIP. So now these 3 subtypes are all part of the WHO for this H3K27 altered diffuse midline glioma. And we didn't have enough evidence previously for this emerging entity, but we do now. So this is a new high-grade glioma in pediatrics, or a pediatric type. The diffuse hemispheric glioma, again a histone 3 mutation, but this time in amino acid 34. These are also grade 4 by definition. Excuse me. And they usually either look like a high-grade glioma, or they can look very primitive, like an embryonal tumor as well. So just keep that in mind. Like the IDH mutant gliomas, these also almost always have P53 and ATRX mutations, and we picked that up with immunohistochemistry. They're almost all adolescent or young adult patients, so if you see this kind of setting and IDH is wild type, think about this tumor. It almost will certainly be this tumor type. And the other clue is that unlike other diffuse gliomas, they're often OLIG2 negative. Prognostically, these are thought to have somewhat of an intermediate prognosis. These are certainly much better than the diffuse midline gliomas that are H3 altered, and they're better than IDH wild type GBM, but they're worse than the IDH mutant high-grade gliomas. So here's the criteria. Basically needs to be a cellular infiltrative glioma with mitotic activity in one of these two mutations, either guanine to arginine or guanine to valine. And we do have that as a surrogate stain by immunohistochemistry, so we can pick that up with immunohistochemistry. So the last two of the high-grade gliomas I won't talk about for too long, but there is one that's both H3 and IDH wild type, and these often will involve at least one of these three oncogenes, PDGFR-A, EGFR, or MYC-N. And then there's this infant type hemispheric glioma that's will involve one of these receptor tyrosine kinase, typically fusions, either the NTRK family of genes, ROS1, MET1, or ALK. And even though these are very high grade and aggressive, these are the only alterations that these tumors have, and so the hope is that they actually are highly responsive to targeted therapy, though we need some more clinical experience with these cases. So this is kind of just a chart showing that, you've got these IDH mutant gliomas with either P53 and ATRX mutation pushing things into the astrocytic lineage, or a TERT mutation and 1p19q deletion in the oligo lineage. You've got the common adult type IDH wild type GBM and two histone 3 altered pediatric types here. Those are the majority of the tumors that we see. Or you can go to that review paper that I mentioned earlier and have a more comprehensive list of the genetic alterations that go with these adult type, 3 adult type, and 8 pediatric type diffuse gliomas. So what else has changed? So in the ependymomas, this large category, there's actually a bunch of molecular subtypes. And so I'm going to use, instead of sci-fi, a real estate quote here, and that is location, location, location. So in the new WHO, you have to first say which of the three major locations they're at: supratentorial, posterior fossa, or spinal, because biologically they're quite different and have different alterations. And at least in some of these, there are specific molecular alterations as part of the definition for these ependymoma types. So by DNA methylation profiling, you can see these 10 or so fairly distinct ependymoma types. And here is kind of a chart in the WHO that shows the molecular alteration and the outcome or prognosis. The ones in green have a very favorable prognosis, yellow intermediate, and red have the most aggressive or worst prognosis. And we'll talk a little bit about these. There's one that has already changed a couple of times. The supratentorial ependymoma that we used to call RELA fusion positive, we discovered it was really the partner gene, the chromosome 11 open reading frame, that was more important. And just as we were working on that, that gene name has changed, so it's now the ZFTA fusion positive supratentorial ependymoma. There's also a new entity that's spinal MYC-N ependymoma that has a very poor prognosis, relatively rare. So what used to be called this RELA fusion supratentorial ependymoma, now ZFTA fusion positive. They're often the clear cell variant, and they have this chicken wire capillary network, but not always. And we have a couple of surrogate immunostains that help us identify that, either L1-CAM, which we use, or in Europe they often use the P65 RELA immunostain, which is even more specific for this variant. We have even better immunostain marker, surrogate marker for the posterior fossa ependymomas. So the PF group A is the is the highly aggressive type, and they have that same epigenetic downstream change that we talked about with the diffuse midline gliomas, with loss of the H3K27ME3. Highly sensitive and specific for this PFA ependymoma subtype. So with a simple immunostain, these were mainly originally identified by DNA methylation profiling, but this one immunostain helps us really identify them with great reliability. So the PFA ependymomas have loss of staining, and the PFB have retained staining. Also, the majority of these are infants and young kids, and the majority of these are adolescents and young adults. So you often get a clue to how it's going to turn out. Okay, in the meningiomas and mesenchymal tumors, there are some changes here as well. We know a lot more about the genetic alterations in meningiomas than we used to, and here are some of the alterations. There's a lot more driver mutations for the grade 1 meningiomas that we now know about. Clear cell meningiomas involve the SMARCE1 gene. Rhabdoid meningiomas, the ones that are more aggressive, involve the BAP1 gene. And there are a couple of other alterations that now have become part of the definition for grading of meningiomas, but also chromosomal alterations commonly involved in progression to higher grade meningiomas. So as part of the essential criteria, it should either be one of the classic histologic patterns of meningioma or variants of meningioma, or have one of the typical driver mutations. And if we see some of these chromosome losses, they're often more aggressive meningiomas. The grading has essentially stayed the same, except brain invasion is not nearly as clear anymore for grade 2, so I now don't put a grade on these. If they're otherwise benign, I just say brain invasive meningioma, leave the grade off. Some series show a higher risk of recurrence, others don't. More importantly, there are these two alterations now that automatically make a meningioma grade 3. Either TERT promoter mutation or, again, this alteration, CDKN2A homozygous deletion. In the sarcomas, this is not part of the WHO. This is a paper that came out recently looking at DNA methylation profiling of sarcomas. And like the brain tumors, it does a really great job of diagnosing them. And I put boxes around the ones that we also frequently see in the CNS, but I won't go over these in any great detail. In the pineal, we've made some progress as well, especially in the pineoblastomas. We now know there are 4 molecular subtypes of pineoblastoma. The most common ones involve one of these 3 microRNA processing genes, DICER1, DROSHA, or DGCR8. The ones that are really aggressive are the ones that involve FOXR2 or MYC, or the RB1 associated pineoblastomas. And there's a specific mutation associated with the pineal parenchymal tumors of intermediate differentiation. At this point, we don't have a specific alteration for the pineocytomas. There's also a new entity in the pineal called desmoplastic myxoid tumor that's SMARCB1 or INI1 altered. These are extremely rare, but they have a much better prognosis than what you normally think of with atypical teratoid rhabdoid tumors that also have these mutations. So we'll spend just a little bit of time on the embryonal tumors. On the pediatric side, the major categories have not changed very much in the medulloblastomas, but I'll talk about further subgrouping that is recommended by the WHO. And there's a couple of newer entities that we'll spend just a couple of minutes on for the embryonal tumors. So for medulloblastomas, I kind of think of these as the age-old war between the lumpers and the splitters. And I would say the splitters are definitely winning. And if you take it to the extreme, we're almost getting to the point where every medulloblastoma is its own variant, much like every human being is its own, his or her own distinct subtype. But it's not quite that bad, but this is where we are. So the Wnt-activated medulloblastoma is still only a single group, so fairly clean. But in the sonic hedgehog group, there's now 4 subgroups. And in the non-Wnt, non-sonic hedgehog, or group 3, group 4, there's 8 subgroups that have been identified. So this is why I say the splitters are winning. Still, though, you could argue, do you need to do all these subgrouping? You know, most people don't, and I think it's okay. Within the sonic hedgehog group, it's still mainly the ones that are p53 mutant that have the really bad prognosis and are often associated with certain hereditary syndromes. And in the group 3, group 4, it's still mainly those that have the large cell or anaplastic histology or MYC or MYC-N amplifications that have the worst prognosis. And you know, again, is it really critical that you separate out subgroup 6 from 7 where the prognosis is nearly identical? Probably not, in my opinion, but nevertheless, here it is. There's a really great summary table in that review paper that or not the review paper, sorry, in the upcoming WHO Blue Book itself, talking about these categories, what are the most common clinical pathologic features of each of these, what are the cytogenetic alterations in each of these, the molecular genetic alterations, and very importantly, I think, what are the hereditary tumor syndromes that are often associated with each of these. And especially in medulloblastomas, they're much more common than you might realize. And so we always advocate for doing germline testing in these in addition to tumor testing. So other embryonal tumors, like the medulloblastomas, we now know there's 3 major subgroups of ATRT, or atypical teratoid rhabdoid tumor. There's a provisional new entity, cribiform neuroepithelial tumor, that clusters with the ATRTs and has INI1 loss, but a considerably better prognosis than ATRT. And then there's a couple of new entities I'll show you. And there's a new subtype of, or subgroup of, embryonal tumor with multilayered rosettes. The one we've known about previously was the ones with these chromosome 19 mainly amplifications. But there's a new Dicer1 altered subgroup as well. So here's one of these new categories, new entities. This is some data from our group of these high-grade neuroepithelial tumors with B-core exon 15 internal tandem duplications. These are in young patients, overrepresented in the cerebellum, but can occur anywhere in the brain. Mainly young kids, but a few adolescents and adults as well. Mainly poor prognosis, but a few long-term survivors as well. So there's still some more work to be done in these. Pathologically, I think of these often when they don't quite fit one category. Here's one case that has these Homerite-like rosettes, but they were synaptophysin negative, and GBM-like necrosis, and ependymoma-like perivascular pseudorosettes. So these kind of mixed features that don't quite fit one entity, we think of these. And then we do a B-core immunostain, which is strongly and diffusely positive, but this is not entirely specific, so you still have to do the molecular testing to prove it's this entity. At this point, it doesn't have a specific WHO grade because we just don't have enough clinical experience. It's probably grade 3 or 4, but at this point we don't know. There's a soft tissue counterpart, and it's still not entirely clear. Is this the same tumor as in the soft tissue, or is this a unique tumor in the CNS? And then lastly, this CNS neuroblastoma or ganglioneuroblastoma that's driven by this FOXR2 activation. These are supratentorial tumors, usually young patients, pediatric patients mainly. But it's important to separate these out because the most recent data suggests they have a much better prognosis than other embryonal tumors. So better progression-free and overall survival than you would guess for certainly a grade 4 tumor. So that's a quick overview of all the changes in the new WHO. Of course, we're not finished. This, the Odyssey continues, and I'm sure, there'll be additional changes once we get to the 6th edition, but I'll leave you with one more sci-fi style quote, this time from Star Trek. Epigenomics, sorry, I can't see this here. What does that say? Anyway, these are the voyages of WHO neuropathologists. Oh, it's the new frontier. These are the voyages of the WHO neuropathologists, their ongoing mission to explore strange new brain tumors, to seek out new entities and driver mutations, to boldly plot what no man has plotted before. So I know that's a lot of information. If you want a song to reinforce some of that data, I have a brain tumor rhapsody on YouTube. As far as I know, it's still the only brain tumor rhapsody. A few years ago, I was in a men's a cappella group, and we were working on Bohemian Rhapsody, and I got the guys to record this alternate version, the brain tumor rhapsody, where I changed the words. So just look it up if you want, and it'll emphasize many of these molecular alterations that I discussed.